My great pleasure and honor for the three of us coming from Athens, Greece, to be in your meeting. Special thanks to Professor Karamustafalioglu, Professor Arisioglu, and Professor Birseus. Did I pronounce it nice? Okay. For having us with you. And we are looking forward to tightening our relationships and having you coming to Athens or to Greece whenever we have relevant meetings for you to participate. It's a beautiful place, by the way. It's my first time. I have been many times in Turkey, but it's my first time. It's the second time for the other two colleagues, for each one of them, but the first time for me to be in Antalya, and it's a spectacular place. So it's a great pleasure. Thank you for coming, and we hope you will enjoy our talks. Insomnia. Everybody thinks insomnia is just one thing. Everybody says, I'm insomniac, has the same insomnia. This is not true. This is what I'm going to present to you. And then the effects of hypnotics on sleep, which relates, of course, to psychopharmacology, because the mainstay of the treatment of insomnia is hypnotic drugs, still is hypnotic drugs. At a certain point, we didn't have any other means of treatment of insomnia. We didn't have the psychotherapeutic approaches. We didn't have other means of approaching insomnia in its management. So, but still hypnotics are the mainstay of the treatment. Look how widespread is insomnia in the general public. About 10% of the general population, no matter where you are conducting the study. The very first study, the seminal study, we conducted when I was in the United States in the late 70s in Los Angeles area. The question was, do you have insomnia or not? And about 1 out of 4 said yes. Of course, insomnia is not just that. It's more than that, and you'll see later on what we mean now by saying insomnia. And if we define insomnia as a chronic problem in the general population, it's about 10% in terms of this being a medical problem. And as you see, just poor sleep or sleep dissatisfaction, the range is very wide depending on where you are conducting the study and what are you looking for. The consequences, many consequences, as you see, from any sort and degree of functional impairment to increased days of disability, healthcare utilization, absenteeism, accident proneness, comorbidity with psychiatric disorders mainly, but also with physical problems, disruption of interpersonal relations, and of course, compromised quality of life. These are the ICD-10 diagnostic criteria, which I was privileged to draft together with the leadership of the WHO at that time in the early 90s. And as you see, it's not just poor sleep quantity, but also sleep quality that counts. Some people say, I'm sleeping for 7 or even 8 hours, but still I feel very bad in the morning as if I have not slept at all. This also is insomnia. So it's not just the quantity, but also the quality. And sometimes the quality is what counts more than the quantity. And has to have some duration, more than 1 month is a problem, and also a certain frequency, at least 3 times a week. This is based on the ICD-10 criteria. We have devised the Athens Insomnia Scale, which does 2 things. These are 2 separate publications in the same journal with a difference of 2 years, I believe. And one, the one up above has to do with the intensity of insomnia, and the other with the diagnosis of insomnia itself. If one scores 6 or above in the Athens Insomnia Scale, has an insomnia, bona fide insomnia in terms of the diagnosis, the ICD-10, and still remains the most the only one scale that diagnoses insomnia and has been translated by now in about 20 different languages. I don't know whether it has been translated in Turkish, but it has been translated in Chinese or in Japanese or in other exotic languages. This is a study conducted by my colleague who is with us tonight, Professor Paparigopoulos, in a Greek population, and it showed what most of us know from our clinical practice, that insomnia increases, its prevalence increases with the age. As people age, it's more frequent, and also that it's more common to women than men. And insomnia, probably, okay, there might be another one that was missed there, but doesn't matter. Insomnia has a multifaceted etiology. It's not just one thing. It's not just sex, or gender, or age, or socioeconomic status. It's a host. It's a sort of a combination of all these factors, and it depends. That's why I told you there are so many insomnias as many insomniacs are around, because each insomniac has a different contribution of these predisposing factors, and of course the different contribution of the precipitating factors, and finally the precipitating factors. And you see how many of these are. Predisposing factors is older age, gender, socioeconomic status, the underprivileged, of course, family or personal history of insomnia, various medical psychiatric illnesses, and most of all, certain personality characteristics. Insomniacs are typically internalizers and deniers and minimizers. They don't I have seen thousands of insomniacs, and when they come to me, they say, "Doctor, the only thing I have is insomnia. Please treat me." And then I sit down. I don't challenge them, but I just sit there and listen to them and speak with them and engage them and have them come again and again and again. And by the third or fourth or fifth session I'm having with them, they have forgotten that they came for insomnia themselves too, myself as well. They are engaged in other issues that are more relevant than insomnia. So insomnia usually is within a frame of other characteristics, and these are the personality characteristics that make these people deny that they are having other problems but insomnia. Usually they have many problems. And the precipitating factors are back in their past, probably 5 years or 10 years before the time they come to you, and they are sort of forgotten or lost in the past, and of course denied, the stressors. And you have to look for them, and once you point to them, they accept them, of course, but it takes a long time to do that. And you see also changes in the evolutionary period and adverse life events of any sort. And the perpetuating factors is poor sleep habits, irregular sleep scheduling, and most of all, the fear of sleeplessness. The fear of sleeplessness is sort of performance anxiety, like with sex. You cannot impose sex on yourself. Once you get hung up with performing in sex, it's compromising the actual effort. The same thing is with sleep. The more one tries to get to sleep, the more difficult for him or her is to get to sleep. So, and this is probably the most important perpetuating factor. And one in treatment has to deal with all these factors, not just with insomnia. Insomnia is one thing, but you see underneath how many other things are. This shows the contribution of the precipitating factors, the predisposing and the perpetuating as a function of time. At the beginning, it's just the predisposing factors, and probably insomnia is not there yet. Then the precipitating factors take over, and finally the perpetuating factors are the ones who are there more robust. Mental health and insomnia, probably most of you are psychiatrists or involved in psychiatry, so I don't need to say that insomnia is a symptom of many, many psychiatric disorders, notably anxiety disorders and, of course, depression. but also that the last item here, that insomnia may be a prodromal symptom of a subsequently full-blown clinical episode of depression or one of the major psychiatric disorders. So be careful when you see someone who is depressed, because he or she may just be prescribed the hypnotic and may be suicidal 6 months later or 2 years later. So these are the main treatment options for insomnia, but don't take them separately. They are separated in the slide, but they are actually usually combined, or they should be combined. Sleep hygiene measures, what to do. Go to bed every night at the same time. These are common sense sort of advice, but don't forget to give to your patients. Wake up always at the same time, or plus minus 1 hour. Exercise early in the evening, not late, because one gets excited and then cannot get to sleep easily. Follow a regular pattern of activities before sleep. Keep your room warm, quiet, and your bed comfortable as much as you can. Of course, sometimes it's very difficult to observe these rituals. And what not to do: do not drink caffeine, do not in the evening, all these things that you see and most of us know, but still, do not smoke before sleep. People are smoking in Turkey, as probably they are in Greece, so it's useful to tell them that. And do not use bed for any other activities except sleeping and, of course, sex. Psychotherapies, cognitive behavioral therapy, which is very fashionable nowadays, but it is also very effective and has proven to be very efficacious. Psychoanalytic used to be very fashionable in the old times, still is, when you are dealing with a person who has personality problems mainly, or borderline or other difficulties that cannot be dealt with CBT. And of course other forms. By now there are probably hundreds of kinds of psychotherapies. Contraindications of hypnotics. I don't know how this slide got here. It should be at the end, probably they're mixed up, but doesn't matter. The obstructive sleep apnea syndrome, which is probably well known to you too. Hypnotic drugs suppress the center of respiratory center, and therefore are contraindicated when the patient has obstructive sleep apnea, and should be recorded in the sleep laboratory, but only if there is an evidence for the existence of sleep apnea. Otherwise, we should record, if we indiscriminately recorded everybody who comes and says, I'm insomniac, we couldn't afford that. We wouldn't have so many patients in the sleep laboratory, as many as insomniacs are. But just keep that in mind. If someone has a heavy snoring and gaps during the respiration at night, gasps. Drug and alcohol abuse, pregnancy, and need for functioning during the night, as doctors and nurses are. Now, I can't tell you how many ways of studying hypnotics are. There are as many probably as studying any other drug that is in psychopharmacology useful. But the most important to me and to most of us form of conducting studies with hypnotics is in the sleep laboratory. This is a simple sort of design that pertains both to clinical studies and to sleep laboratory studies, but for sleep laboratory studies is indispensable. We record, as you see, 4 nights in the sleep laboratory. We just disregard the first night because it's an adaptation night, and then we take the mean of the 3 nights, 2, 3, and 4 is a baseline value for the patient's sleep, and then we record as many nights as necessary to see how the drug affects sleep, and then we discontinue after 1 week or 2 weeks or 3 weeks of drug administration, and we see what happens after the drug is abruptly withdrawn to see whether there is some problem after the discontinuation. And what we see is with the old good hypnotics that we still have, the benzodiazepine hypnotics, with the long half-life hypnotics, what we saw is that the drug was very effective at the beginning, and during the intermediate period that you see 16 or 18 days later, total sleep, total wake time, the opposite of total sleep time. Wake time during the night decreases as time goes by, but also, as you see, this decrease is less and less with the passage of time. And there is some tolerance developing, but this tolerance is not as much as you will see with the short-acting hypnotics. And after discontinuation, there is either a carryover efficacy in the short-term withdrawal period, the nights 33 to 35, or in the intermediate term withdrawal period, there is some rebound, but very negligible one, which means that the total wake time overshoots the baseline value. Here with the short half-life benzodiazepines, as you see, for a few nights at the beginning, yes, they are very effective, and then they lose their efficacy, and tolerance develops very quickly, rather quickly, and it's more pronounced than with a long half-life. But what is even more spectacular is the rebound following discontinuation. And you see this is true for the 3 nights following withdrawal for the mean, but for the first night sometimes it's really terrible, as you will see later on. And the people, of course, if they see that after discontinuing the drug, they have this problem again, and actually it's even worse than it was on baseline, they are more prone to keep taking the drug. Do I have another 5 minutes, Mr. Chairman? 5 minutes? Okay. 7, thank you. Okay. And you see here summarized the differences between the long and the short half-life hypnotics. We are talking always about the benzodiazepine hypnotics and some of the, in general, some of the newer non-benzodiazepine but benzodiazepine-like hypnotics, the Z drugs, the zaleplon, zopiclone, and zolpidem. And you see the differences. With the long, whatever is in light blue are the beneficial effects, and what is in yellow are the non-beneficial effects, the detrimental effects. So there is a sort of balance between the benefits and the shortcomings of the long and the short. With the long half-life, of course, you have the marked carryover effects of sleepiness and psychomotor and cognitive impairment, which may be very risky during the day if one has to conduct certain precision sort of action during the next day. With the short half-lives, of course, you don't have these carryover effects, but you have the rapid development of tolerance, which you saw already, the marked propensity for rebound insomnia, which is the overshooting the baseline of insomnia, and some unexpected cognitive effects, memory, and other cognitive problems, which may be really difficult. For instance, if one is physician and gets called during the night for a patient, and the doctor had a pill of short-acting benzodiazepine, he may have amnesia during the next day on what he said to the patient or to the carer of the patient during the night, which is really terrifying. So, the question was, are all short-acting benzodiazepines alike, or they are different, especially the new ones, the Z drugs, the zopiclone, zaleplon, and zolpidem? And we conducted a study in collaboration with Anne Whitehead, which is not a psychiatrist, not a pharmacologist. She's a statistician in the UK, but she's famous for her talent in conducting meta-analysis. This was in the late 90s, as you see, and we came up with some interesting findings. First of all short-acting benzodiazepines and non-benzodiazepines, namely zolpidem and zopiclone, are equally effective because they increase total sleep time and they decrease the sleep onset latency considerably at the beginning of their administration. And these are many studies that were included in the meta-analysis. Unfortunately, not all the studies could be useful for looking for tolerance and rebound phenomena, but still, although all short-acting benzodiazepines and non-benzodiazepines, like hypnotics, had similar efficacy, they differed in terms of tolerance. And you see triazolam, for instance, had quite a lot of loss of efficacy compared with the other two drugs, midazolam, which is another benzodiazepine, of course, and zolpidem, which is a benzodiazepine-like drug. And even more spectacular was the rebound, differences in rebound, both for protezolam and triazolam. There are huge rebounds, considerable rebounds, which was not the case with midazolam and zolpidem. So it's not just the short half-life, it's more than that. And if you see that the first night, for triazolam and zolpidem, you see the difference there. So probably it's not just the short half-life. It's the dosage. The higher the dosage, the more intense the rebound phenomena or development of tolerance eventually. The administration period, the longer you give the drug, the more intense are these phenomena. Individual characteristics have to do with the person who takes the drug for whatever reasons, and of course the chemical class, we saw that already across the two. So there are some new and emerging hypnotics. I don't know how new melatonin is, but still has not been used for many years and still is not used as much as people think they should be used. Probably rightly so, because it's not an effective drug. It's hypnotic, I mean. It's a sleep aid. It's of course a sleep aid, but it's just for jet lag and for some biological rhythms aberrations. There are melatonin receptor agonists, and Ramelteon is in the market in the United States, and there are the emerging ones, the GABA agonists, the 5-HT2A antagonists, and the orexin receptor antagonists, which have not been as yet promoted. And I will finish by saying that the combination treatment is the best answer to the management of insomnia. Always combine drug treatment with sleep hygiene measures. Sleep hygiene is indispensable. And when combining drug treatment and cognitive behavioral psychotherapy, one should start with both treatments, gradually reduce the drug after 1 or 2 weeks of treatment, discontinue according to response, sometimes may need to be given for a longer period, and continue CBT and sleep hygiene measures for a long, long time, and then reevaluate the patient often. This is the key. The key is to keep contact with the patient, to follow up the patient. Once an insomniac, maybe forever insomniac, unless you take care of him or her, usually it's her, in the proper way. Thank you very much for your attention.